Welcome to the November 2017 SurgeonMasters web conference, Malpractice Risk Reduction, Best Practice Tips from My Attorney. A few SurgeonMasters web conference reminders. This web conference is being recorded. Discussion is designed to be open, but nothing is completely confidential. Please click Raise Hand if you have a question, or you can type it into the chat box for a response. With that, Jeff, take it away.
Hello, this is Dr. Jeff Smith with SurgeonMasters, and I welcome you to this monthly web conference. I'm looking forward to this. This is a great opportunity. It's been a little time since I've been in touch with my awesome attorney, Dr. Robert Fessinger, or Bob. Bob, welcome. Why don't we click to the next slide to introduce Bob so everyone can see a visual. Bob's an attorney that works with CAP MTP. Had personal experience with Bob and represented me exceedingly well in a malpractice defense case. And one of the main reasons that I brought Bob to the SurgeonMasters web conference was because there were many times when I was going through that experience that there were messages that he kept trying to teach me, and he was being an awesome teacher, and I was being I think a really good surgeon and not necessarily as open-minded as I probably should have been, although I don't know, I think I did a pretty good job of listening and absorbing what I could. But he had a lot of good messages that I just kept thinking to myself, yeah, this is really sinking in now. It would have been nice if I would have let this stuff sink in earlier, and it might have prevented a lawsuit. So with that, a little bit long-winded introduction, I'm going to let Bob say hi.
Hi all, my name is Bob Fessinger. I'm a practicing attorney here in California. I have been practicing for 27 years now. I can't believe I just said that. My entire career has been defending doctors from initial inception of a case all the way through numerous trials. I love speaking at things like this because I think the more information we can give to physicians prior to lawsuits is always beneficial. So when Jeff called me about this, I first smiled, saying that case was tough and hard, and he did learn a lot as well as I did, but I would love to do this. So that's where we're at.
Well, thanks again, Bob. What we talked about was a little bit just giving a little bit of background of some simple concepts, and I'm going to turn it over to you shortly to give some of your introductory comments, and I might interrupt you, but just a reminder to all those listening, if you choose to ask a question, you can raise your hand. You can also put something in the chat box if you want, and we'll relay that, or we'll make sure that your microphone is unmuted, and we'll come to you to ask the question. So with that, let's go ahead and shift over and let Bob give some of his helpful tips as an attorney for lots of doctors.
So, it's interesting when people ask an attorney to speak, it's usually about the actual litigation that occurs, what happens during the lawsuit. But when Jeff talked to me about how can we decrease the risk of a lawsuit, since I've been involved so much, I just went back and thought about all I've learned from talking with doctors, plaintiffs' attorneys, even plaintiffs. And I've been able to come up, with what I think doctors need to do to at least attempt to minimize, the risk of getting sued. Let's be honest, the fear of a lawsuit's always there, and the first thing you can do is provide excellent care. That is number one, of course. But secondly, you also have to think about, even if I'm providing excellent care, what can I do to reduce the likelihood of a lawsuit if an error occurs or if someone's unhappy with my care? So when Jeff and I were talking about it, I thought, well, number one's easy. Number one is the communication between a patient and a physician. And that, to me, is everything. You always hear about the doctor's bedside manner. it is really, really important to a patient, much more important than medical discussions at times. That doesn't mean I don't want you to have those medical discussions, but your bedside manner does matter. And the communication and the rapport you have with your patient really has been shown in studies to lessen the likelihood that somebody might sue you even when an error occurs. Because let's be honest, errors are going to occur. They're always going to occur. But what you have to think about is, if it does occur, what can I do to potentially lessen that risk? So when we talk about communication, I always start with when I go in to see a doctor and I've got things to talk to him about, you can kind of tell by a doctor's body language immediately if he's truly interested in your health care. Some doctors have very busy offices. Some doctors have to see numerous patients in a certain amount of time. I always think about something I learned actually in Jeff's case, where the plaintiff's attorney kept asking, do you sit with your patient? Do you sit with your patient? And I think it's a great point, because it shows to me that you actually want to listen to what that patient's concerns are. So number one, which is listed here, would be don't dismiss or even appear to dismiss the concerns. They're there because they need medical help. So sitting down, listening to them is really where I think step one should be. Next step would be pretty much within the same realm, just listen carefully. They're there to tell you what their problems are. They don't even know it from a medical standpoint what their problems are. They just say, it hurts here, or I have this pain here. You have to take the information that they give you and decide what the etiology of those problems are. So listening very carefully to your patients, I think, clearly is also, you're supposed to anyway, but that's probably one of the most important things you can do. I also think about realistic expectations, because, we all come in to see a doctor and we think he's going to fix us. And that's what we want you to do. But you as the physician have to take what we tell you and make realistic expectations known to that patient. Every patient wants a guarantee. We all want guarantees. I want to guarantee you're going to make me better when I don't feel well. But I think as a physician, your duty is to actually listen, determine what the issue is, and then set a realistic expectation. Talk to the patient about what you really expect to occur. We're going to do this. We're going to do this. In your mind, you'll have differential diagnoses. But really, all they care about is, how do I get better? But you have to explain to these patients what the expectation is that you want to get to with the treatment you're going to give them. So again, it all comes down, and I call it the bedside manner, but it's more than bedside manner. It's truly listening and caring about what that patient's talking to you about. With regard to communication, I also think giving them clear answers is important. You learned in medical school how to come up with a diagnosis and talk to the patient about it. But to be honest, as I just stated a little earlier, I just want to know how you're going to make me better. You, as the doctor, have to make sure I understand whether I can be better, what I need to do to get better, because I will have a lot of questions as a patient, and I want answers to those questions, even if you can't give guaranteed answers. So that doesn't mean you have to give the correct answer. It just means you have to talk with the patient, listen to what his questions are, and answer them, whether they're answers they want to hear or they don't want to hear. But, I always think about the cancer doctors and what a tough situation they're in, because if there's cancer, it's never going to be a fun answer, but it still has to be a clear answer. So when we talk about communication, it all comes down to making sure that you valued them, you understood them, and you informed them. And that's how I see the first step of lessening any risk for malpractice, is to talk to your patients. Really, really important. There's a couple little tidbits that I've learned. I even do it in litigation at times, but when you are, and I know it's a little different now with electronic medical records, but when you walk into a room, you should greet the patient by name if you can and make eye contact with them. I just think it helps us as your patient feel at ease. Nowadays with the electronic medical records, and even I see my intern is doing this at times. He walks in, he does sit down, but he faces the computer immediately, and then he starts typing as he's asking me questions, and I just don't feel you're building any relationship with your patients at all, and that's the way it occurs. I think you gotta look at them. It gives value to what you're doing for that patient there. Anybody have any question about how important the communication is with your patients?
So I'm putting together just some of my own thoughts as well as people are deciding whether they have some questions. But so I think for the most part, you're going to get a universal communication is very important. And I think whether they're questions or challenges, because you've given a couple of great examples that I may go back into. One of them is just electronic medical record. If you're picturing that scenario, seeing both sides, the legal side and being the patient side, if that doctor is pressed for entering stuff into the computer, keeping up, not necessarily making people wait too long, because that probably doesn't help any either. How might they do a hybrid? Is there a way where you would ideally have your physician greet you, get the eye contact, sitting down, engage you, and then maybe still be able to accomplish some data entry into the computer where it wouldn't be a turnoff because there's something that's been achieved?
So it's interesting, Jeff, that you asked that, because I could give you the easiest answer to it all, but it takes more staff, and that's probably not what you want to hear. But scribes are great. There's a lot of doctors who are using scribes nowadays to type everything in while they actually treat the patient. I'm not saying that's going to happen in every office, but I have seen that. I was in an office a few days ago where the doctor was sitting down with the patient while somebody else was typing it in. I know that's not available in all offices, but that would be a great way to handle it if you could. But, let's be realistic. That's probably not available for all offices. You just have to be able to figure out what the balance is between the information getting in right there and then and actually making that connection with your patient. I think about when I first started practicing, when everything was written. A lot of doctors, they wrote the notes after they saw the patient. Now, you might not get the detail you need as of today, because when we talk about documentation, I'm going to tell you how important documentation is. So it's a tough balance to come to, but you have to always think when you walk in that door to see the patient, how can I help that patient out? Is it talk with the patient about something? Is it listen to the patient? Is it give them answers? So you have to fill out each patient. And as you know, Jeff, you also have to make quick determinations about those patients. Do they understand what I'm talking about? We had a situation where, the patient needed help. The doctor was discussing it with him completely, but really he didn't have the mentality to understand what that doctor was saying. And there's another issue for you. You have to, you have to be able to read a patient. I always tell people in deposition when I'm representing them, if he asks you something, what does this mean? I always look at my clients and I say, he wants to know what it means in layman terms, because this isn't your boards where you got doctors on the other side of the table wanting to hear the medical terms and your use of them. These are lay people who want you to talk English to them. So it's a tough balance to be able to make that, get that rapport with your patient, but also document everything, because as we're going to talk about in a little while, that is way important as well. And
then the other thing that you alluded to, and just to bring the the story in the circle, which is part of the point why I invited you, and I'm giving the surgeon perspective and you're giving the attorney perspective. But I do recall that one of the issues that came up in my case is that, and I'm almost starting to figure out how I'm making excuses for it, but I think that there were a couple of encounters with that patient that I didn't actually sit down, that I came into the room felt a little bit small. I think chairs were occupied. I think even early on visits he came in a gurney, so there was really no room or no great way to sit down. But the lesson I learned from that experience, because what helped drive it home for me was making a greater and greater effort to sit down. So that, as you said, it's both actually listening, but it's also the ability to demonstrate that you're listening.
I agree 100%. When that was, if you remember, that was exactly what they kept asking, and I found it so unusual. But I see how it works, because people are trying to present, that you're in there, but you might not be really communicating well with them. And I found it to be a great point, and I talk to all of my clients about that now. When I talk to them about minimizing the risk, I think it's a really good point that the plaintiff's counsel made in that case. It doesn't go to the step of malpractice if you don't sit with them, but it's a point well taken. So
right.
They were trying to use that as, that should be the standard of care. And let's be honest, that's what the standard of care is the care you're rendering to the patient, not whether you sit with them or not.
Right. And again, I've done a lot of things in the last few years that kind of have shifted gears as far as effort to listen. And I think one of the things is when we're aware of their diagnosis, when we're aware of likely treatment recommendations, we have the potential to go into the room with kind of an agenda of sharing that information with the patient and it's been helpful to make an effort to listen to what else the patient is there for besides hearing that information. They very often will say, yeah, I just want to know how you think I'm doing, or I just want to know an answer to a question that I'm going to ask. Am I healing? Am I getting better? Am I doing the right things? Or various things like that. But it's sometimes the questions that we are not expecting them to ask, and giving them the opportunity to ask those and listen to their questions or even their comments can be very helpful.
Not only that, sometimes you have to, acknowledge their thoughts, but you might have to explain to them why it's not right. And I think that comes across a little bit easier if you are building a rapport with them, if the communication level is well. I've seen that happen as well, where people think they know what's going on, and you take it from a different standpoint. But if you just say, and I know you wouldn't do this. No, that's just not the way it works here. No, you listen, you acknowledge, and then you explain your reasoning to the patient. It works. It does work. I also think patients do want to be involved in the decision-making process for themselves. So, I go back to when I was a kid. I just went in, the doctor told me what I was going to do, why I was going to do it, and how I was going to do it. Today, people actually, I think, want to partake in the decision-making process. So I think it's also important that you present, options to the patient. You discuss it with the patient, and you should be recommending what you believe is the best alternative for them. But you also have to listen to what they have to say about their own decision-making process for their own care. So,
right.
When I start here, as I said, I started with communication because to me, it's the most important part of I was about to say attorney-client privilege, but I mean the patient-physician relationship. So, but I'll move on unless somebody wants to ask me anything about that.
I think we're good. We may come back to it later if people have questions later, but go ahead.
Okay, so another way I believe that you can reduce risk is your staff, because they are the face of your office. They are the face for you before you've ever seen a patient. And we've all been in that situation where a staff member either can step up and make somebody super happy, or the opposite, where the staff member somehow turns off that patient. And right there and then, the relationship has a problem from the beginning. So, you walk into an office, you expect, you stand there when you get to the front of the line, if there's a line, that they're ready to greet you, ask you why you're there, what time your appointment is, etc. But I've seen the issue where they're on the phone, their back is turned, they're not paying attention to what's going on at the front. So to me, and I want this to happen in every office, but I think there should be, professional etiquette by all staff members, especially the front staff, all staff members, but especially the front members, because they are the first ones to greet those patients. People are talking about all kinds of things in the day, especially with the internet and social media of today. But the discussions that are at the front should be about, one, getting these people in, telling them information necessary for their visit, and moving on. They shouldn't have to listen to, people talk about how, their kid didn't get into this school, or did you watch that TV show last night? Because it can be off-putting to some patients. So I always start there with you have to train your staff well enough to handle situations like that.
That's an excellent point. And it's really one that demonstrates the very broad range of patient experiences, in the sense of just different clinics that I've gone to as a patient or with a family member, that those with incredibly refined professional etiquette, it does come across as, wow, this is a really nice place.
We've all sat in an office and there's been a long wait, and we don't have any idea why we're waiting as long as we are. And I will tell you, every 3 minutes that I'm waiting past my time, I'm getting more frustrated and more frustrated. And I think going back to the staff, teaching them how to handle that situation is really important. There's nothing wrong with explaining why there's some delay. You might be in surgery. OBGYN might have got called to the hospital to deliver a baby. There might have been a patient who walked in who was very sick, who needed to be seen right away. We're compassionate people, but I can tell you, when we know nothing about what's happening, frustration, again, can cause dissatisfaction. And all of this goes to, if there's dissatisfaction of any sort, you're losing that relationship potentially with the patient. And again, as long as your care is good, quote, you won't get sued. But if there's any issue with regard to the care, what you're trying to do is reduce the risk. So it's never nice. It's not fun. We're not going to the doctor's office like we're going to see a football game. we're going there because there's something wrong. And it's really important that all the steps from the minute I walk in that door to the minute I leave work out to my satisfaction. And it's a hard thing, but that's the way it has to be, because you've got to do what you can do to, the main reason we're here talking today, reduce any risk for malpractice. So I don't see why, a lot of times people behind the desk will get frustrated. We're going as fast as we can. Just give them a little bit of an explanation. Have no problem with that. I think that should be done in every office.
Great point. So just out of curiosity with, and you may get into this a little bit already with other stuff. I hope I'm not jumping ahead on you, but other, I don't know, examples of where, I mean, obviously these are a correlation of things that in your experience in cases come up, but is there any examples in the staff relations where that clearly has contributed to the negative patient experience or the desire to sue?
I had a case about 4 or 5 years ago where it was a failure to diagnose case, and it really dealt with lab results, and the patient continued apparently to call, at least alleged that she called in 3 to 4 times and kept getting the blow off. The labs aren't here, we'll call you when they come in. And if there could be some explanation, maybe if the staff member had just said, let me make a call to the lab, see if there's any delay or when they're going to be available, and then I'll call you back. You can see the difference in somebody who makes that comment to you as to somebody who says, they're here when they're here. And they took the deposition of that front office staff member, and of course she didn't recall the telephone call. But I always wondered, going right back to this, is did that interaction have anything to do with this lawsuit? So that's exactly where you can see it come up. The case ended up settling. It was a case that needed to settle because one of the most important things you can do is, and this is kind of going off, but if you order a lab, I highly recommend you look at that lab. I know that's not what we're talking about, but let me tell you, I had a surgeon on a case order labs, and he was really just looking for one of the lab values. And on page 3 had to do with liver, and he never even looked at page 3 because that's not what he was interested in. And when it came down, the patient ended up having a terrible problem, and he goes, Bob, I wasn't even interested in that lab value. I wish they would have never run it. And I said, yeah, but you ran it. You got to look at all 3 pages. So that's a lesson for all doctors. If you order it, you need to look at all of it. But you're going to sign off on that, and if you sign off on that first page, that means you read it all. Now we're going to talk about a little bit of documentation later. So, the other part of your staff is, I think your staff are your eyes and ears out there. They're out there and they see what's going on. They're observing patients when they come in or even when they leave. If they see that a patient's potentially unhappy when they're leaving for the date, something, either they got some information or they weren't happy with someone in your staff or they weren't happy with the information you gave them, your staff can serve as your eyes and ears, and maybe they inform you, and you can make a follow-up call, because a follow-up call means you actually care. So I look at the staff as a very, very important cog in the care that you give to patients.
That one's pretty huge. I'm not saying that the other points that you made so far don't resonate with me. They resonate significantly, but that's a pretty good opportunity for improvement that I see for myself. That I occasionally get staff that will tell me challenging interactions on the way in. My medical assistant's actually very good at that when she observes it, but I'm not sure that I have quite the same mechanism on the departure, and that's a really good point. If they would highlight if there's concerns or issues, that's a great opportunity to make sure that that can be either remedied or at least followed up on.
Yeah. We all know you're busy. You're not going to be able to call every patient that might be unhappy, but, you know, knowing that, having that knowledge in the back of your mind, you might think, one, can I make that call? Do I have the time to make that call? Or two, when the patient comes back, I want to make sure that I communicate with he or her about it so we can continue this communication, this relationship going.
Yeah, I mean, I don't, and even the staff might point something out that is something that I don't necessarily even have to handle. It still could be a process where it's just an ongoing communication about an issue of either difficulty scheduling the follow-up appointment, or it could be something on the way out that they didn't understand, and it may be something very easy for staff to follow up on, but then I'm aware. And then also, if there's that one that's at that higher level where it's an issue that only I can address, then certainly that's a potentially very worthwhile phone call to make.
Yeah, I agree 100%. All right, so obviously one of the most important ways to lessen the risk for malpractice cases is the documentation, and it's clearly changed in the last 15 years. It's all going to electronic medical records, and there's some, you know, issues that we're starting to see with electronic medical records. I'll get into it, but let me at least go into, and if you read what I wrote here, I think it really sets the point very well, that documentation that's absent, incomplete, improper, or illegible can negatively affect the quality and continuity of patient care. But it's also really important that it can affect the defense of a malpractice claim, even when your care was appropriate. And that last part is so important. The writing can affect the case, even if the care was appropriate. That lays it all out for you. We're going to talk about it in detail, but if you can just take that in tonight and learn from that, you've learned something here today. So I met with a client a couple months ago, and we talked about his documentation, and he was like, I don't have enough time to write the type of notes that everybody wants me to write today. And I shot back at him. I said, would you rather spend time in court for 3 weeks, 5 days a week, from 9 to 5 with me, or document a little bit more with each patient? And he smiled at me, and I think he got my point. It just tells you how important your documentation is, because I know none of you want to be in trial with me. Trust me. Nobody ever says to me, let's go to trial on a case. It should be fun. It's not fun. And each one of you who have been in trial understand that. It is not a fun time for the doctors. It's my job. But for you, people are criticizing your judgment, your care, and it's not what you really want to hear. I'm sure you would rather be practicing medicine and helping patients. So that point's really important, that you need to document. So I always also start with this, and I learned this in the trial. We won the case, but it was an 11-1. There's 12 jurors, and I always like to have a 12-0 if I can get it. All we need is a 9-3, but I want to talk every one of those jurors into agreeing with me that my doctor's care was appropriate. And on a case I had, it went 11-1, and I remember after the trial, I went over to that one juror and I talked to her. I said, why did you rule against my client? And she said, if it wasn't documented, it was not done. And I said, well, wait, you don't have to document everything. But she came from a contract world. She worked with contracts. And in contracts, if it's not documented, it's not part of the contract. It doesn't really jive in the medical malpractice world, but it's an important point, because there are people out there who believe if it's not documented, it wasn't done.
Very interesting.
Yeah, I found it to be pretty interesting as well. So we know that the medical record for a patient's the primary source of the information. And I always, when people ask me, well, what should I document? I always tell them this. I want you to assume that you're taking over my patient. Let me turn that around, the other way around. I want you to assume I'm taking over your patient. What information do I need to have to properly treat this patient? What knowledge from the previous healthcare provider? And that is the documentation that you should be providing in each of your notes. Assuming that patient leaves, are you giving enough information to the next healthcare provider to treat that patient? And some people will say, well, they can call me, they can talk to me, but no, that doesn't happen, as we know. They read the records. So documentation is everything when it comes to medical malpractice, when it comes to treating patients and reducing the risk for a malpractice case. Now, we always hear about how doctors have messy writing, and it is true. And that's changing a lot with electronic medical records, but documentation that's either absent, incomplete, improper, or illegible, it has a way of negatively affecting not only the continuity of the care, but also that case. If people can't read it, one, don't forget I have to send cases to experts. And if they can't read the writing, we're going through a process of trying to figure out what it says. I will tell you, there's been a lot of cases where I can't read my client's writing. I'll call my client and we'll talk about it, and he can't read his own writing. So it's kind of important for you guys to actually document legibly. Again, I know that's changing because of electronic medical records, but the goal for the doctor should be to give complete, timely, factual, accurate information that can assist not only you but anybody else. And the only way to do that, and again, we're going back to the balancing between talking to the patient and documenting, is to get it down in the record. So if we're going to get into specifics, we can talk about what I think is most important, especially for surgeons, is informed consent. So I've handled hundreds of surgery cases, and I take the deposition of the plaintiff, and the first question I ask when I get to this part of the deposition is, all right, did the doctor discuss with you the risks and complications of the procedure? I'm trying not to be facetious here, but at least 75% of the plaintiffs say no. Now, we all know that there's not a surgeon who doesn't discuss risk and benefits, alternatives with the patient. But the patients, one, are either going to lie and say it wasn't discussed, or two, and there's been studies on this, they really don't remember it because they don't really care about that. All they care about is, how do I get fixed? But you have to care because you, as you know, have to give them the information. You don't get to make the decisions. So you have to give them the information because they have the final medical decision to make. So with regard to documentation, I've seen everything. I've seen RBAs /, I've seen risk discussed, I've seen risk including laying out 40 things discussed, and people will say, well, how much should I write? And I always say that's a tough call. I'm of the opinion you should write down what you discussed because it protects you. But you don't need to discuss rare risks. So should you be discussing those and writing them down? I don't believe so. I think you need to write down the ones that are the highest potential for occurring. But you can't. I don't believe you should just write down informed consent discussion occurred. You should be writing specifics for the informed consent discussion. When it comes to deciding what to do, you have a differential diagnosis. You believe the patient needs one treatment or another, and let's assume they had a second opinion, and the other doctor believes they needed something else. Well, there are conflicting, thoughts between doctors. So when you're discussing why you believe a patient needs a certain treatment, I think you need to write down not just, recommended surgery, blank, blank, blank. You should write down what you are basing that decision on. The labs, the evaluation, the examination, etc. If you had a consultation, you should be documenting these things, guys. It's very, very important that your notes show what you did. Any questions so far about those two issues?
I'm not seeing any at the moment. And we'll let people chime in if they want to. Hopefully they'll raise their hand. Oh, we have one, maybe. Hold on, because I see the mic being played around with. Either one of our, any of the folks on want to say something? It's clicking back and forth, so I don't know.
I think it's you and I. Well, if they do, they can jump in. I'm always willing to stop. I'm trying to actually stop to make sure I don't just keep talking over people if they want to ask questions, but that's fine.
So just from this standpoint, I mean, and maybe you would get to this, but there was a couple things that it may not be on your primary list of things to discuss, but I think it certainly came up in my case. There was a couple favorite phrases that you seem to drive home with me, and I don't know if you remember those. I remember one of them, and that you would describe as expected.
Jeff, I'm sorry to interrupt you. You just muted everybody, so we weren't able to hear what you just said, and it just came unmuted.
All right, so okay. I'll say it again. So there was a lot of phrases where you've sort of described them as kind of key phrases that can be really helpful, and I know that one of them was that if a physician or surgeon makes an observation of something that other people might not know exactly what that means, that if you add a comment like expected, an expected amount of pain or an expected amount of bleeding or an expected amount of this, that was potentially very helpful.
It is, because you're not leaving it to what your custom and practice would be. You're actually documenting what was discussed or what your thought process was at the time. I'm always of the opinion more documentation is better. That doesn't mean you have to write a dissertation, but you should be talking to patients about what is expected. It goes back to the communication. We have to all have reasonable expectations. We all want to be fixed, but we might not be. And I think those type of terms are really important in the medical record, because they're going to say, "Oh, I just remembered he said he was going to fix me," but you're laying out that it's the expectation would be this, assuming treatment went as expected and physical therapy occurred after the fact, he would be able to get back to his job within 3 to 4 months. Those comments are great, because even though I'm sure that's what you would have discussed, it lays it out there for a jury to see it, because they're only using their eyes, and juries have become very visual. We use a lot more documentary evidence in trials now than we did in the past. It used to just be a lot of discussion. I try to use the medical records when they're beneficial to me, and if you're documenting well, they are beneficial to you. I also think it's really important to document follow-up instructions more than, come back 3 months, or come back if your fever gets high. I think you should be writing down specifics, like call me if your temperature gets over 101, as opposed to call me if your fever returns, because then you're giving them specifics and there's no ambiguity as to the instruction you were giving that patient. So if you can document those things, it benefits you. I also feel the same way about telephone calls or nowadays text. I have a case right now where I represent an orthopedic surgeon, and he allows his patients to text him. And by the way, I'm okay with that, but it's really, really important that you don't delete those texts because they're going to become an issue at some point. In his case, he got a text from a patient on Thanksgiving Day. And in that text, the patient said, my leg, he'd had a knee replacement. My leg is hot, it's red, doc, what should I do? And my physician client texted him back, said, I'll be at the office in 15 minutes, meet me there. Most of the time, it would have been a telephone call to the exchange, then a call to the doctor, then the doctor calls back. There could be time, which is of the essence. So he ended up going to see him, and then he ended up going to the ER because he actually did have an infection. But those text, emails, whatever they are really, really important. So if you are going to use that type of communication with your patient, I know you can't print them off until hopefully they'll never become that issue, but they should not be deleted because they might become really important for us. And the phone companies, it's very tough to get that information if they even keep it for a certain period of time. But the same with phone calls. I mean, I've had phone calls where you don't remember the call coming in, and it was you gave some really good information. You said get to the ER. Well, they didn't go to the ER, and you don't have any documentation of it. And what the patient says is, I wasn't instructed to go to the ER, so you should be documenting those phone calls as long as they're pertinent. I mean, you can't document everything. We get that.
That's helpful.
I also don't think, and I call these event reports. So let's assume there's some type of a untoward event that occurs. I never understand doctors who write in their chart, malpractice carrier contacted, call to my attorney. Those are not part of your care for a patient. And even though I understand why doctors might write those things at times, those are not part of your medical chart. Those should be in a separate document. That's an event report. That has nothing to do with the care of the patient. But you'd be amazed how many files I go through where if there was some type of an untoward event, on the left side of the chart, it says, with regard to one of the carriers I do work with, called CAP MPT. I'm like, why is that in the chart? So here's where I'm telling you, don't put it in the chart. That is something that should be separate and apart. Any issue related to risk management doesn't need to be in the chart. And we see it a lot too.
Yeah, I think that's not really well taught. But now it is because you've just taught us. But
well, it makes me laugh because I'm like, what is the doctor thinking when he's writing that in the chart or she's writing that in the chart? But I mean, you're just trying to document. All we do is tell you document, document, document. I get it, but you're all intelligent people. You should be understanding what needs to go on the chart and what doesn't. A couple other things that I think you have to be careful with charting on is, and this comes up in lots of my cases, deals with criticisms of other care provided to a patient. A patient who came to you for a second opinion. They're coming to you for the opinion. Even if they ask you what you think of the other doctor's care, you should be very cautious in making judgment in your records about somebody else's care unless you've reviewed their records, documented some summary of what they've done, because so many times I see it where they just listen to what the patient says, and let's be honest, how many of your patients truly understand everything that's going on? They don't, but I see it. I saw it in an orthopedic case about a month ago, and he literally was shredding my client, and then I went to take his deposition. He was shredding my client in the notes. I went to take his deposition, and I asked him what he was basing it on. He based it on something the patient told him, which wasn't even factual. So you really have to be careful and cautious about putting those type of statements in your records. But we do see those. We really do see those. I also think you should be careful about documenting a conclusion that you weren't a witness to. I had a case where, well, somebody was having an x-ray done and they fell off the table. And the doctor wasn't there for that, but later on he wrote, patient fell off exam table. And to be honest, it was probably true. But really, as you not witnessing it, the better comment would have been patient fell on the floor, patient found on the floor next to the exam table. So, you know, it's hearsay. We talked about that in trial. If you didn't see it or witness it, you just got to be careful about what you're documenting, conclusions like that. Any questions about documentation so far?
I think you're on a good roll.
Yeah, I can talk about documentation in all the years of my practice. Trust me, this is something I can talk about because you see so many things. Let me give you a couple. I'll give some more tidbits, but let me give you a couple examples of where documentation has been really important in my cases. And I will use at this point electronic medical records. I represent a pain management specialist here in town, and as we all know, with the electronic medical records, pull downs are being used by the doctors because that's the way they're set up. Well, those pull downs, I hate to say this, probably in the next 10 years are going to be the standard of care. The question's not going to be how was your care appropriate. The question's going to be, did you use the right pull down on the medical record? Why do I say that? Because we're seeing so much error using electronic medical records. It's going to take time. Everybody understands it. And things can be explained away. But let me give you an example of what I'm seeing a lot with regard to electronic medical record pull downs. So I have a case where, as I said, I represent this pain management specialist, and he was giving epidural steroid injections to a patient, and he gave an epidural steroid injection appropriately. The patient stayed in the office for a period of time, left the office, started to have obviously the problems, and ended up with a massive hematoma. Obviously, they needed emergency surgery immediately, and that was all done. The next office visit, the patient came back to see my client. I look at his note because there's now a lawsuit on this, and it said gave epidural steroid injection. And I'm like, I doubt that's true since you just had an emergency massive surgery to, get rid of the hematoma, 3 weeks earlier. But what happens with those pull downs is you're pulling them over from one visit to the next, and you have to be very careful not to do that because you might be involved in situations like this where things that you did not do on the next visit are documented that you did do them. So that we're going to see a lot of, and I think it's going to take time for doctors because you are copying, and it does save time to copy and move over. But I would highly caution you to, if you're going to do that, to read it before you save it, because we know once you save it, it's staying there. So I caution you to read it before you save it to make sure that what you're documenting is what you did on that visit. Have any of you seen that issue come up with any of your cases?
Yeah, I mean, I think I'm hearing that with a lot of people dealing with a couple things. One is that I don't know if I have any personal examples of the carryover. I've heard of people with too much being repopulated of previous notes and a little bit of that material. It's interesting. I think the electronic medical record is a big challenge because of the new issues that it's kind of raising, and you're highlighting a couple. I think we need to be attentive to the other things that are coming out as a result of difficult or poor documentation based upon the EMR.
No question. Let me give you another example of the opposite. And this, I don't see this as much anymore, but I represented a neurosurgeon a few years ago. Really, really good credentials, older gentleman, and we're looking. He got sued over a laminectomy, and we're looking at his post-op notes in the hospital before the patient was discharged. And we get to, post-op day 1, and I'm looking for his note, and I see his name, and it says, quote, "doing well," end quote. Well, that might have worked 20, 25 years ago, but I would highly recommend that nobody say "doing well," and that's the whole note. And it just goes to the point. You have to document, why is that patient doing well? Is that patient ambulating? Is that patient having less pain? Is there less bleeding? Are they alert and oriented? But doing well tells the reader nothing. So, I don't see that as much anymore, but in all my years of practice, I've seen some notes that literally don't tell us anything. So I just caution you against that as well.
So, Bob, these are all excellent. I'm just going to give you a little bit of a reference because I know you're partially not necessarily jet lagged, but travel lagged. And we have just a few minutes. If you have some key additional points that you wanted to make, or if you thought it would be of any value, just to summarize some key take-home messages, that would be great.
Well, it's funny. I just looked at the clock. I'm like, oh my God, it's been an hour, and I can talk forever. So I'm glad you just showed me that. Oh, we're coming to the end. But I hope you have at least taken from our discussion here and that the physician-patient relationship is more than just a doctor taking care of a patient medically. It's much broader today, and I think it's even changing even more, every year. I think, just to summarize this whole thing up, when you walk in the door, look at that patient in the eye, listen to that patient, talk to that patient, and explain to that patient. That is your job as a physician, to give us the appropriate information to make a reasonable decision on what we want done with our own bodies. And then how do you protect yourself is that you document everything about it as much as you can without going overboard. Because when I represent you in a lawsuit, what am I basing my opinions on? What is my expert basing his opinions on? What is the plaintiff's and the plaintiff's expert basing their opinions on? They're basing them on what's written in that chart. So those are the two big points. And I wanted to actually, I'm going to throw you for a second here, Jeff, as this is another talk I give. Now, we can talk more about this if you want to do another one, but I'm also speaking next month on whether it's okay to apologize for medical errors made. And I'll just throw that out as a tidbit because I'd love to speak to your group about that, because the answer is you can apologize for medical errors, but there's a way to do it. So if you invite me back, we'll talk about medical errors because I think it's really important in treating patients as well.
Bob, that's awesome. Once again, thank you. And I'm not going to totally wrap up because I'll give people a little bit of a moment if they want to chime in with questions. It could be that our audience is, again, very quietly and passively listening and absorbing all your great pearls. But please, anyone who does have a question before we all sign out, please either raise your hand or unmute your phone. But Bob, thank you so much for doing this. I like the tease. I will take you up on the offer one way or another. We've talked about either future web conferences, and we'll do that on how to give the apology, or at one of our future SurgeonMasters meetups, having that as a discussion point might be a great way to do that as well.
Yeah, sounds great.
Anyone want to ask a question? Hopefully we haven't prevented you. We have a couple on, but I'm not sure if hopefully Paul is controlling the mic so that I'm not having to worry about that. Well, thanks. We'll call it a wrap, and lots of super useful information. The cool thing is we've recorded this, and we'll share it with those that weren't able to make it this evening, which I got a few notes from those people saying, sorry, I can't make it. And we'll give them an opportunity to listen to our web conference. Thanks so much for being with us, Bob.
Anytime, and I'm always available if anybody wants to talk about things. See you later.
Have a good night.